Okay, welcome everyone to another one of our expert webinars where we invite world-leading experts in the field of fertility, reproductive medicine, and reproductive health to give us their insights and expertise across their areas of excellence. Today we are very, very honoured to be joined by Professor Bart Fauser. Welcome. Professor Fauser is a professor of reproductive medicine, a gynecologist and former head of Department for Reproductive Medicine and Gynecology. He's also the chair of the Division of Women and Baby at the University of Utrecht and the University Medical Center Utrecht in the Netherlands. Professor Fauser is a fellow of the Royal College of Obstetrics and Gynecology and honorary member of the European Society of Human Reproduction and Embryology. He is a world-leading expert in areas across human ovarian function, especially PCOS and POI, ovarian stimulation, IVF and women's health, and has published close to 500 peer-reviewed articles. He's one of the most cited scholars in reproductive medicine across the world. So it is a massive honor, both personally and professionally, that we have just some of his time today. So Professor Fauser, thank you so much for joining us today for what we hope will be a really engaging session on an area that we both have a lot of passion for, which is the rise of digital diagnostics and the future, essentially, of women's reproductive health.
Thank you so much for having me, and I'm looking forward to, for sure, it's going to be an engaging exchange of ideas.
Great. Well, as our sessions go, we are usually very conversational. I think overly scripted, certainly over PowerPointed talks lead to a little bit of just a formulaic approach. And actually, when we had our initial discussion about this, we both got quite excited about, the areas of just, I guess, similarity. But from your perspective, you've had a very long career, a very long esteemed career, and have witnessed the rise and fall of many proclaimed promises when it comes to revolutionary changes, be that in IVF treatments, be that in assessing embryos, or be that in reproductive and gynecological care. Can you tell us from your perspective what is, I guess, the future of fertility?
Wow, that's a very challenging question.
It's a minor question.
Let me start with a focus on infertility treatment. But when I started my career, I'm not going to reveal when that was, but then it was basically the treatment of married heterosexual couples who tried to have children and failed to do so, and then visited first a general practitioner and then a doctor. And this is the very early days of IVF, so there were not too many tools, certainly that were proven efficacious that we had to treat these patients. But that's how it started. It was a medical diagnosis and a medical treatment, usually done by doctors working in a hospital environment. Now, if you compare that to where we are now, then you realize how huge difference have taken place. First, in terms of the possibilities to treat infertility, and for sure IVF is number one in vitro fertilization. It has developed a long way, in the beginning with big steps, with different medication regimens and new technologies being used, improvement of the whole path of all the steps in IVF. But the time of big steps are over, and now it's much more fine-tuning, probably automation, the use of big data, artificial intelligence, but it's relatively small steps compared to the early days. And of course, that's not a surprise. It's always like that. When something new comes up, major improvements will take place early on. Number one. Number two, as you can see, in the beginning, it was basically treatments taking place in hospitals. And to a great extent, that's no longer the case. Certainly with the focus on IVF, indeed, I think now it's the minority of IVF that is practiced in the hospital environment. And you could say the great majority of patients don't really need a hospital environment. And of course, it's by definition not so very patient-friendly. So therefore, if possible, activities has been outsourced. That makes it better controllable, easier to deal with. You know, you only have your own responsibility for a given program, but also that made it very commercial, if you wish. So money became a big issue, and with the risk, the advantage of being more patient-centered and coming with good results, the disadvantage of that there may be overuse of IVF itself and its added technologies. And more alongside this, but it's relevant that you see, of course, the treatment of a heterosexual married couple who want to conceive and fail to do so. That now is a minority. And now there are all other sorts of people who want to have children, either individuals or couples, same-sex couples, LGBTQ. So the techniques originally developed for infertility are now more and more applied for individuals or couples, which has nothing to do with infertility per se. They just don't conceive.
Yeah, I think that's a really interesting shift between IVF and fertility practices being used solely for the infertile. And now it is definitely much of I will not say that IVF is a choice, but it is an enabling choice within couples for whom a family wasn't possible. However, I think there's a very gentle balance that needs to be struck between essentially something that can become commercialized. I often think that IVF, one of the criticisms I have of IVF is that it is one of the only medical treatments that a patient can simply request it, apart from possibly cosmetic surgery, where a patient can go and ask for a treatment without actually necessarily even going through a thorough triage to understand the root cause. And there's various different scenarios, as we've just pointed out, whereby same-sex couples don't need to be infertile in order to need infertility treatment or fertility treatment. However, I think given the over-commercialization of IVF as a field, or assisted reproduction as a field, it does lend to the inability to differentiate between understanding somebody's root cause of fertility. And you say that the protocols for stimulation have changed significantly, and it's much more fine-tuning now. But I still think that there is an over process, maybe like a production line with patients when going through IVF, whereby there is less of a personalized approach to firstly understanding the root cause of their fertility or infertility before ever going through a stimulation protocol. I think there's the standard tick box of let's check the ovarian reserve markers and let's check the partner's sperm. But there are, when we look at the NIH website, there are 11 different causes listed of female infertility. And yet we don't really thoroughly examine every person down to the lifestyle level as well before putting them through the process.
There is indeed the difficult balance between doing too much or too little in terms of diagnostics. Doing too little is sort of not the nihilist approach. IVF is an empirical treatment, and quite often it doesn't really matter what causes the condition. IVF will do the job. So, and there people literally say, you better save the money for expensive diagnostics. You better save that for the treatment. That's one side. The other side, of course, is the more tests you do, the more chances you will have to have an abnormal result. And then it's tempting to say, oh, I found the problem associated with infertility. But that's not really the case. It can be an association and not a causal relationship. And all these quote-unquote knowledge about causes of infertility, this is textbook knowledge, usually not very well founded based on scientific data. Of course, if tubes are blocked due to infection, then we know the cause why a woman cannot conceive following intercourse. But that's one of the rare occasions. And for all the others, endometriosis and fibroids and now what else? It is not so very clear, even including quote-unquote ovarian aging markers. So on a group level, that may give a decreased chance for fertility, but there may be individuals within that group that have a very significantly decreased chance, whereas for others, decreased chances may be minimal. And the challenge, of course, is going from a group to an individual.
Yeah, hopefully that's something that, a more personalized medicine approach to treating somebody as an individual rather than as a group may help. You have published close to 50 papers on prediction models in fertility treatment using, multivariate prediction models, which is something that's very close to our heart at Fertility. It's exactly what we wish to achieve for somebody achieving a pregnancy in the absence of assisted reproduction or IVF. I'm interested to hear your thoughts and your perspectives on the use of digitalization and algorithms for treatment and for.
Yeah, interesting question, and certainly, of course, in the context of e-health, I think these represent fantastic tools to move that field forward. Intuitively, of course, everybody says, we want healthcare personalized, that fit our personal needs and circumstances. But the paradigm in healthcare, even today, is still very different. This is referred to as evidence-based medicine, and this is the holy grail for many, also many clinical researchers. And that is usually, you have a big study with many individuals included, and then you compare intervention A and intervention B, and the one that shows better outcomes is the best. In reality, of course, these patients are usually very heterogeneous within a group, and one group may respond a little better than the other, but we all know, all doctors that have been involved in those kind of trials know that when you look in the details, usually even within a given group, the response differences of individuals are huge.
We've witnessed this many, many times. We have a huge research team, an incredible research team of scientists. And one of the initial things that we set out to do was, before we make any statement on anything, whether something's effective or not, let's systematically search through the literature to see, systematically review it and do a meta-analysis to say, of all of the literature out there on this, is there anything concluding in one way that it works or the other way that it just doesn't work? And almost across the board, what is the most frustrating thing about systematically reviewing the literature, and you'll see this every time you read a systematic review or meta-analysis, the conclusion is all studies are very heterogeneous. So there's just too much, there's not enough proper controlling within the way we do these things. And the most impossible thing to control for is an individual patient, right? We can tell certain parameters about them, but you can, when it comes to fertility, even if you took every detail there was about one person, you still need details about the partner or the sperm that enables that.
It's more than that. As it's about difference in lifestyle, ethnic differences, the difference in whether you live in New York City, you lead infertility care. Of course, that's completely different than if you are living in sub-Saharan Africa and you need and these are just maybe individuals of the same age and they may need the same treatment, but all the circumstances, the context, I like the term, the context is completely different. So we have to indeed acknowledge it, and what you need for personalized medicine is really a different research approach. And in that respect, what you are doing might help a lot. So we started doing this in the early 90s, where we thought And also I like that it's the natural cause of disease approach. So, you know, maybe even you can give a certain condition a label, but what does it mean? What does it mean in terms of infertility, or in terms of bleeding, or in terms of quality of life, or in terms of future health risks? And what you need for that is just follow these individuals. So you have a group of women defined based on whatever criteria, and you follow them over time. But of course, under circumstances where the aim is a pregnancy, now usually within 1 or 2 years, you know whether it's going to work out or not. But there are many other questions relevant to healthcare, to women's health, that may take 10 years of follow-up. And who's going to do trials with a 10-year duration? Who's going to sponsor trials with a 10-year duration? Yeah, but very, very few. And also the whole funding system is not ready for this. So you need a completely different approach, and therefore, and I think the fundamental idea here is you don't compare intervention A and intervention B. You compare patients that all undergo the same intervention, like infertility treatment, whatever that is, and then you say which are the patients with a favorable outcome compared to which are the characteristics of patients with, and you need big data for that. And indeed, in that respect, e-health and artificial intelligence is going to be hugely helpful. And this is not something that we have invented in the fertility arena. This is debated everywhere in all the big journals for cancer treatment, for cardiovascular disease, for preventive secondary prevention. So this is discussed everywhere and picked up, some areas more than others. So you could say in that respect that fertility care, infertility treatment is running behind. We are pretty resistant to change, and we always say, oh, be careful, because what we do now is great, and we are reluctant to make changes. But, you know, the whole world around us is changing, and we better be part of that.
You've joined the revolution. I think you started it a long time ago. Yeah, and I think on to exactly reiterate your sentiment about the data. We've been perpetually disappointed by data sets and how small the data sets are in papers that are actually seminal papers that make big sweeping statements. In fact, these are statements that go into diagnostic protocols, they go into diagnostic guidelines. These are the rules by which many clinicians then adhere to in order to diagnose somebody. And like you said about a diagnosis, what is a diagnosis and what difference does it make if the treatment for that diagnosis doesn't work for a majority or even a minority of patients? And I think we have an I guess, a desire to put people into a bucket when it comes to a pathology. Somebody is PCOS, somebody has endometriosis, when really there are probably many different subclassifications of these. These should be umbrella terms, and there should be very many subclassifications within them, so that actually within those subclassifications, everybody gets a much more tailored treatment that would suit that classification of PCOS or endometriosis. Yeah,
and we may, and I like that, because diagnosis, and I say privately, I have those discussions often, that people want to know if there's a problem, what is the diagnosis, what is the label? You know, you want to have a ticket, this is it. That's an illusion, that's not reality. You can have a label, but if the label doesn't mean much, and if it's a container, or if it doesn't have any implications for your treatment, then why would you want to have a label at all? But it's apparently in the human being, the thinking, you know, we have a problem and I know what the cause is.
But also I think it's also to do with people getting to care soon, right? If you cannot put a label on it, you can't seem to get. And I think this is probably a systemic problem within women's health, is the inability to get, whether it's a label, whether it's a diagnosis, just the inability to get to secondary care, because the gatekeepers of our care are primary care providers like
right.
GPs.
And that's a very practical, but also to broaden it even more, what is now much debated in my country, and I've been part of that debate from the beginning, that the whole issue of women's health, it is clear. And I doubt that the UK will be any different. But in the Netherlands, it's well documented that women are worse off in the healthcare system compared to men, because we know less about women's disease. Usually, if diagnosed at all, it's diagnosed later. Women visit hospitals more often. Women visit general practitioners more often. They use more medication. They are less happy. They're more often depressed. Blah, 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 blah. This is not good news. And infertility is part of that, or a relatively small part of that. So the problem is even much broader. We just know much less about the female body compared to the male body. And the whole medicine, the way we practice today, is based on research mainly in the 50s and the 60s. And these were all research performed by men, but also the patients included were all men.
Yes, I know. It's one of our biggest bugbears. We took the streets of London with our Mind the Gender Health Gap placards, because we just felt so annoyed that today, still, when we send blood samples and laboratory reference ranges are based off male bloods for testosterone. And, these are not just male hormones, these are female hormones. And yet we have this reliance on, the default being a male body, and anything else is just an anomaly. And to me, I think, as I've said this before, as a geneticist, we expect so much detail for a diagnosis. We expect so much to understand every single thing, whether it's a single base pair change within somebody's genome. And when it comes to huge issues like women's health and the individual conditions that affect billions of women, the rhetoric is still, we just don't have enough data. And I just think, when are we going to call?
Yeah, right. So
when are we going to call that and say we have plenty of data, you're just not collecting it, and plenty of willing people. And we saw this change in people's attitude. Instead of being, as you mentioned at the start, a hospital is a terrible place. For often people get more sick in a hospital because, psychologically it's not a great place to be in. Obviously there are real reasons for being in a hospital, but so much of women's health is very private and personal, and so being able to take that anxiety away from them in any way to enable an at-home diagnosis or test is part of our mission, number one. But secondly, how we actually even began as our journey was that we had started a clinical trial and knew that we needed to recruit women from clinic. And so that whole system of having to approach somebody in the waiting room and say, do you mind being part of our study? And they're in this zone of thinking, what do you need from me? What do you want from me? And everybody, if they're waiting in a waiting room to be seen by a doctor for any kind of procedure, is in a vulnerable position. So we found it really difficult. And actually, I would at the time I thought, unfortunately, lockdown hit and all essential gynae clinics were closed. But now I think, fortunately, that was amazing, because it forced us to be, resilient and say, all right, how do we recruit women? And we put up this website, and 7,000 women said, I want to know more. And that was really what ignited this in us to say, we can actually enable women to find out about their bodies, but also be participants in a greater movement, which is, gathering insights for it all across the board, not just by the time somebody gets to clinic. I think taking information or even blood or symptoms from somebody when they're already in clinic, it's almost too late. We should be collecting data from a young demographic of women. And when they're a little bit older and older again, what we repeatedly see with the people who take our test is that when something's wrong with them, they invariably will say, well, I've actually had problems since I was 16, but I was put on the pill, or I've actually had problems since I got my periods, but have been, taking contraception since. So it's only when they come off it to have children that they realize that this was never a necessarily healthy reproductive system, and that way long ago they should have had treatment or intervention.
No, but I think it also represents a shift. The healthcare system, of course, by nature is very reactive. You know, we wait for a problem to occur and for somebody to realize, oh, this is a problem. And then they come to us, and in the early curative way of thinking, we thought, we are going to solve the problem. You know, we're going to diagnose, say what it is, and we're going to fix it, and we're all happy. That was the classical medicine approach. Now, we know that life is much more complicated than that. So now, and what you are doing is reach out to individuals who are not sick. Some of them may get sick or may have an increased risk to become ill, but and this is more proactive. So then you're early. That's number one. And number two, of course, you change the balance because once an individual is already a patient, it's sort of the old-fashioned doctor relationship. The doctor is here and the patient is there. And now, by being more proactive earlier, it's no longer a patient. It's an individual, a client, a woman, if you wish. So now we are more in the role of a counselor, providing relevant information for the problems of presumed future problems of this individual, and also therefore helping women to make well-informed decisions. So change the balance towards more autonomy of the individual. And that too is a trend in general healthcare system, that people that say, you know, it's not whatever, your lifestyle and smoking and obesity, and then, you know, you put it on the plate of the hospital and say, you fix it. You know, it's part responsibility for the individuals themselves as well. So it is their problem. We can help, we can counsel, but they should be part of the solution also.
Absolutely. I think that the term responsibility is the perfect term. We call it reproductive responsibility.
Yeah.
You know, we are all responsible for so much of our life, so much of our lives. We can't get away with not paying our bills, not looking at our finances, not monitoring, you know, whether we have enough money in the bank to pay for the things that we're going to spend. And yet we don't monitor our ovarian reserve before we plan a family. And we plan all parts of our lives, whether it's, you know, your career, your next holiday, where you want to live, or a house you want to buy. And yet we don't plan years in advance. And people say we do, but the reality is, I think the responsibility has really shifted, and it's almost taken the carpet under from so many women's lives, because there's a narrative among the kind of social scientist realm, which is that, you know, women are choosing their career and women are choosing, you know, a lifestyle over a family. And the reality is we have no choice but to work. We're not living in the days where one income could afford to even rent a house, let alone buy. And that, I think, is very unfair on the responsibilities, really, that we've all of a sudden, from a personal perspective, it's not a case where women are, I guess, negating the need or even ignoring it. They're just, for many, they come up for air in their 30s going, I need to have a baby. I mean, that's the thing I need to do. And I think that's really put a terrible shift on the onus to do a quick fix, which is, you know, go and freeze your eggs, do something, be responsible, which is another financial burden for so many women, when actually what they should be doing is saying, where am I now? You know, am I reproductively healthy? In as far as we can see, am I monitoring my ovarian reserve? And while we know there are limitations, which we'll get to in a second, about, you know, monitoring ovarian reserve, there are certainly upper and lower limits to where action could be taken a lot sooner, and the information that one would get from testing their fertility or reproductive health would change their path.
One element which has not been part of the discussion so far is also, and I like sort of the analogy, family planning. I think everybody has an idea about family planning and what it means. Usually it's being part of a biology class in high school, and that's about sex education and about preventing pregnancies. But if you think about the term family planning does not only mean not to have children if you don't want it. It's supposed to mean the other side of the coin as well. So what to do if you would like to have children and which measures to take. And slowly you see a movement towards, yes, this whole idea should be broadened and should be part of high school education already, that women and men, not just women and men, are aware of this.
Ik weet niet wat je bedoelt met...
Sorry.
Muzie, je moet niet doen, yes, wees al luid.
Just a second. Somebody's trying to help. People are aware of this at a very early age and may want to think about this. In the future, in the near future, testing of ovarian reserve may help, that women are informed that they are destined to have decreasing fertility at an early age or at a later age. It all might help in informed decision making. Then at least you know where you are, also at an early age where it's not relevant at that particular moment, but that people can have indeed reproductive responsibility starts earlier, starts before you consider to have children. But where am I in life? And you may want to make your life choices, and this be part of that equation.
When we kind of, I guess, when we look as well at the statistics around infertility and the prevalence and how many people are affected, 1 in 7 heterosexual couples are affected. And we know that global fertility rates are falling because of our environment and because of, a later trend towards even the time that somebody would start having their family, or even thinking about it. That, to me, suggests that so much more could be caught if we were just thinking more preventatively about it. How many of that 1 in 7 was their infertility actually age associated? Yeah. And we know that age is the #1 determinant of infertility, and that seems to be the growing, increasing trend across reasons for people attending fertility treatment, is that they are of advanced age. But there are many within that group, even at a younger age, they would have suffered. So we've had 28-year-olds, we've had 22-year-olds, we've had 25-year-olds, all who have premature ovarian insufficiency, and they would never know. It may be that those 25-year-olds aren't going to even attempt to have a baby until they're 35, in which case the label is advanced maternal age. So I guess they just fall into the same trap of just blaming infertility on age, when actually maybe a huge portion of those they could have known much earlier on, and they would. I
think the increased use of fertility care indeed is, as you say, that often a more advanced reproductive age of women, and therefore decreasing chances. But don't forget that there's an increasing demand for fertility care. Not in the context of heterosexual couples, but by individuals, male and female, and by same-sex couples, and by the LGBTQ community. Of course, it varies from country to country, but in the Western world, for sure, this has grown rapidly. The number of individuals who approach clinics for care in this context, often also cross-border care, that they have to go abroad because they can't get the interventions that they aim for in their own country. And this is also very much about autonomy and human rights. Everyone has the right to reproduce, no matter what circumstances. So that too is a huge shift if you compare now versus 10, 20 years ago.
I couldn't agree more. It's amazing the ways in which we've been able to bend biology and move it from a realm which was solely patients to actually individuals with that are maintaining their reproductive autonomy through various pathways like surrogacy or egg donation. And I think that brings us to an interesting point around autonomy, and that kind of choice versus being told what to do by your doctor, not being told, but I guess you go to a doctor because they're an expert. You want them to bring all of their years of experience to the table and say to you, here's what the best possible route for you is. And we've seen that there are, because of the commercialization of IVF clinics, that many patients can go, and still the most common age for freezing eggs is 39. And to me, there's almost a level of dishonesty when it comes to clinics offering treatments to patients who have poor prognosis. And yet, how do you battle that with how do you draw the line as a professional who says your chances are pretty low, but as a patient that is demanding something? I think there's been a real change in the dynamic between the doctor-patient relationship, whereby patients are coming armed and they're telling you what to do.
Yeah, of course, there's not a simple answer to that. To be honest, in my country, in the Netherlands, up till recently, amongst many of my colleagues, there was sort of the old-fashioned idea that doctors knows what is best for patients, and then the doctor would say, this is a very low chance intervention, we're not going to do it. But of course you can imagine that many people are not happy with that. They say, am I part of that evaluation also? Can you decide for me? And we know that even with very low chances, quite often patients say, I want to have everything possible to be done. Also later on, if it fails, then I know I've done everything possible. So, but you can see that's a tight balance, and certainly also in that kind of discussion, whether you like it or not, a commercial the commerce is being part of that discussion also. Of course, if you practice medicine with a fixed salary for all the, so it doesn't matter how many procedures they do, it's quite likely that your counseling will be somewhat different than if you run a private clinic where you get paid by the procedures done. And there we have to take our responsibility as doctors, but of course under those circumstances it's easier to give in. You know, if you advise negative, it's easier to give in and say, okay, if that's what you want, we're going to do it. But certainly also in the Netherlands, to be honest, really quite a few patients went abroad because they insisted on having interventions which doctors said this is not wise, and then they went to Belgium or to Germany. So that is, so it's not an easy balance. For sure.
It's definitely difficult to balance autonomy versus, I guess, the cold hard facts. And we definitely live in a time where it's much harder, in a very sensitive generation of people, that it's actually very hard to deliver some very hard facts when it comes to the potential success or evidential failure of a given treatment. And that I think brings us really nicely to the limitations of fertility testing. We, from the very beginning, with fertility, have never ever offered an AMH test on its own. It's something we refuse to do. People have asked us many times. They say, I know this AMH marker, which for anyone who doesn't know is a marker over ovarian reserve. It's produced by the follicles or the potential eggs within your ovary, and therefore gives us a relative idea of the abundance or lack thereof of eggs within somebody's ovaries. And so it's used as a kind of a surrogate marker for somebody's fertility. However, one marker in isolation is just simply not enough to give somebody a thorough examination of their reproductive health in general. So when we always talk about hormone health and reproductive health and not just fertility, because essentially you cannot extrapolate a substantial piece of information without including aspects of people's lifestyle, their biometrics, symptoms, potential conditions. And that's kind of what's led us to developing this essentially clinical diagnostic tool for reproductive health conditions, in addition to giving somebody insights into their fertility. So in your experience from, I guess, this ongoing debate about AMH not being a sufficient marker to tell whether somebody is fertile or not, do you agree that it is still a very promising candidate when we look at physically scanning somebody's ovaries and counting, and comparing that result with their AMH level? We see concordance across the two.
Mm-hmm.
And while we say you cannot predict whether somebody can or cannot have a baby, above a certain threshold, I agree. However, below a certain threshold, there is no doubting that somebody has a very, very extremely low AMH. They will struggle to conceive certainly much more than somebody with a higher AMH.
AMH, beyond any doubt, is by far the best biomarker for ovarian aging. I think there's no discussion about that. But there again, I think it comes back to the idea about group medicine versus individualized medicine. So if you compare two groups of the same age, let's say 35 years of age, and a group with a higher AMH and a group with a lower AMH, for sure the group with the lower AMH will have less chances to conceive, either without medical intervention, expected management, or with interventions like ART. Number one. On the other hand, there again, it's just like what we discussed earlier. Within that group, there are huge differences from one individual. So it is good, it's a good predictor for a group, but it's less good a predictor for an individual. So AMH again is the best marker, but AMH alone in terms of fertility counseling for an individual woman saying, what are my chances? Can I just wait or should I? And indeed what you are saying, if it's really low, it is usually bad news, bad in terms of fertility potential, but in the normal to higher range, it is more problematic. The problem also with AMH, I'd like to refer to it, it's a damage done situation. So when your AMH is low, it affects your prognosis, but there's basically nothing you can do about it, except maybe for oocyte donation, but for the rest. So of course, the real challenge is to look for markers which can be assessed at an earlier age, whether there are still choices. And biomarkers, almost by definition, may not be suitable for that. But I think it's fair to predict that within now and a couple of years, we will have the added possibility of looking at genetic markers. And of course, Helen, you're the expert, so you can say with greater authority how this works, but it looks like, and because ovarian aging, the endpoint of ovarian aging is menopause, the complete cessation of ovarian function. And we see, number one, AMH by itself at a young age is not a very good predictor. If you do repeated AMH measurements over time, it increases significantly the power to be able to predict age of menopause. That this is well studied now, and that's a clear statement. But also looking at the genetic markers, SNPs, single nucleotide polymorphisms. The first studies in this area appeared 15 years ago, 20 years ago, maybe, from Rotterdam, by the way, and they started, and then the whole series, and now already with a series of SNPs combined, you are already fairly good at predicting age of menopause. So, and I'm not aware of those studies being published yet, but my prediction would be that the combination of AMH and these genetic markers are
plus lifestyle.
And of course, next to these are indeed markers
very powerful.
In addition to, so, and then you will get, I think, more and more close to something that is clinically useful at an individual level. And I think what you have been doing with fertility is, I think, number one, finding the right language to reach people. I think that's you stand out in that, in being having achieved that, and now reaching big, and you have the tools to be able to do this prediction analysis, because we can now speculate, and we're based on rational considerations, say this is likely to, but yeah, that's good as a starting point, but it's not good enough. We need data. We need data. Proof that this is
honestly, part of our mantra is, everybody pushes an annual, your smear test, you should be doing an entire reproductive health test. Everyone should do an annual fertility test. That is your true way of monitoring your ovarian reserve. Some people have, one we've had within the team, even some people have within the team, everybody monitors every month. It's part of our own internal data collection we have some very, very motivated volunteers to understand exactly what happens throughout a year and the dynamic changes that can happen. But for some people, that drop is significant.
Yeah, like we discussed earlier about IVF and the risk for over-treatment and add-ons. It's here as well about fertility tests. Mm-hmm. Now, you know better than I, but there are way over 1,000 fertility tests e-health tests being developed. And most of them, how to say it politely, is not high quality. And in that respect, still people usually are asked to pay for that. So there too is the risk for exploitation and creating expectations that are not realistic. So like in the IVF industry, so to speak, it's also in the e-health industry. You need to take responsibility, and indeed there are many people that are very skeptical about the entire development. I see it as a great opportunity to move it forward, but only under the circumstances that it's done seriously, that expectations are managed, and that indeed you take the responsibility to not just be there, but also evaluate what you are doing and building proof how valid this is.
I couldn't agree more. It's so often we see, companies popping up and they're led by, not to say non-experts is an understatement, they're led by business people who have an idea and see a market opportunity. Yeah. And I find that horrific, actually. I still don't consider this a market. I consider this global health, when it's, 51% of the planet and we're being told, is there a market for it? I'm like, I don't care what you're talking. I don't care about talking about markets. These are human beings. And the fact that we don't have the data, to me, is just simply not good enough. So we've done our absolute best to get the best and the highest quality data. And the last point, I guess, around fertility testing is the importance of understanding that you may have a high ovarian reserve, but ovarian health is really important as well. And so our lifestyles have changed significantly from our mother's generation. We are a generation of women who have a lot more choices, and perhaps those choices are leading to, I guess I always say we're choked by choice at this stage, whereby the choice to delay your childbearing years actually doesn't necessarily serve you, and that when we over-focus on a narrative of using technology to delay, to freeze, to rely on, like it's okay, I've got IVF, I think is quite damaging. And as a society, we actually need to really shift. In such a digital society, there are fundamental, really basic things that we need to change around our attitude towards work and children. And I think it's a huge responsibility falls on the workplace to actually accommodate women to have children, to not be pushing women to just, it's okay. And the amount of workplaces that will pay for their female employees to freeze their eggs. And I think that's, at a time, I used to think that was amazing. I thought it was so progressive. And now I think that's the opposite to progressive. I think it's actually, I think it's actually using women saying, we'll take you for your good years, and don't worry, you can have the eggs back when we're ready, and we're done with you. I think that's the narrative needs to be much more around supporting women to think that they feel it's comfortable to have children and that there'd be childcare at the ready. But it's part of a bigger mission, I think, for us, is changing those conversations. So we have just 2 questions here, or maybe they're comments. So I will read those if that's okay. The first is to say, the information for online diagnosis must come entirely from the data that patients choose to reveal. The advantages lie in availability and speed through automation. What disadvantages do you see, and how could they be alleviated?
A very good question, and I think it relates to what we have discussed before. Of course, it's up to the scientists to think, what are relevant parameters allowing us to reliably predict future fertility potential. Of course, it's up to the individuals to decide which of those data they would like to share. Mm. And science allows us to do a prediction analysis even if we don't have the data complete. But for sure, at an individual level, the accuracy will decrease significantly. So if we don't have all the information in the system to make a prediction, it is going to be less reliable.
I think actually it is an amazing question. One of the biggest omissions from data collection is when people don't realize that something might have an effect on their reproductive health, and therefore they're not training themselves to understand that input one, or whether it's a dietary input or a lifestyle exposure, actually has an effect on their fertility. We tend to isolate reproductive health from just general health. And I think that is, again, something that we're trying to get as many metrics as we can to see what the effect is on what could be coincidental or what could seem insidious or non-related to an effect on your fertility, but actually could have a massive impact.
Yes, and it's more and more clear, both in women and in men, that reproductive dysfunction is often associated with added health risks later on, general health risk, metabolic conditions, cardiovascular conditions. So reproductive health is significant for the individual, way beyond reproduction per se.
Beyond reproductive health, yeah. So and that's why we know from menstrual cycles that irregularities actually are amazing predictors for lifelong health problems and longevity in general across cardiovascular, neurological and bone health. Our reproductive function significantly affects our overall health, and that is something that we definitely need to stop isolating the two. That your reproductive health should not only be important if you are planning to conceive, or if you are if you're planning to conceive, or even if you've had children. I think there's very often people find that if they're not planning on having children, they don't regard their reproductive health, which they shouldn't. But from a medical standpoint, equally, you are treated more carefully if you're planning on having children. If you've already had your children, or you're not planning on having children, it's less of an issue.
Helen, one addition to that, reproductive health not indeed just being important for reproductive potential and for later life health, but also now there's a whole new trend developed in the last 10 called periconceptional medicine, which emphasizes that the health of a woman before she conceives is a very, very important determinant of pregnancy complications,
health of baby,
exactly, healthy baby, and maybe even long-term health for children. So there are multiple reasons to improve reproductive health, not just to get pregnant, not just for long-term, but also for the offspring.
Yeah, reproductive health should not be a means to an end, which is a baby. It should be a means to overall health. Thank you so much. I'm going to take one more question here, because it's one that gets to me every time. She said, "Thank you for your time. Very interesting. In the wake of the Theranos scandal, how do organizations overcome public skepticism about at-home diagnosis or non-clinic testing?" The Theranos scandal is to me the biggest scandal about that is the fact that incredible laboratories were set up and did not get used. I think we can disassociate ourselves from them by actually having not just gone to university, but gone to secondary and tertiary university. Everyone in our entire organization has masters and PhDs, and we are committed to real science, as opposed to with the Theranos scandal, where she left university. She didn't even complete her undergraduate degree. It's done a massive harm, I think, to perceptions of being able to determine diagnoses from blood. However, I think we can hold our heads up and say that we have done everything by the board, and that at-home diagnosis through these means, we've done all of our systematic, we've done concordance and clinical trials proving the accuracy of our non-clinic testing. And actually, I think that we're smarter than that. I think people, as in you are smarter than that, people are smarter than that, and they recognize that. Certainly, actually, in the case of post-COVID, we no longer, not only do we trust at-home testing, we expect it and rely on it. And I think we've evolved from needing huge pieces of, huge vials of blood in order to only take a small amount for a sample. I think the future of health in general is this neo-clinic approach, where you have at-home testing, and in the case that you should need it, you go to a clinic. But in the absence of true need, digital tools are the future of being able to diagnose people, because at the end of the day, doctors are a tool in themselves, in that they have to take in information. Using the information, they have to decipher and give a diagnosis. And I think there's a much more powerful way of doing that with a lot of data. And then the second question, they said, are you seeing women become more proactive than reactive about their fertility health already? Yes, certainly. We have been amazed by our data that, though many people assumed, and I get it, that we're called fertility and therefore people think we just do fertility testing, but we are very much about reproductive health. And when we ask people why they're here, we ask, are you just curious? Are you planning for the future? I.e. maybe freezing your eggs or thinking about that. Are you experiencing symptoms, or are you actively trying to conceive? And everyone said, you're only going to have people who are actively trying to conceive. And in fact, a huge majority are women who are just curious. And I think that lends to acknowledging how innately curious we are about our fertility. It's something that if we don't remind ourselves, everybody else in conversation will, at the various life stages that we have. Okay, great. I'm going to just ask one more, because it's of your expertise, is around hormonal birth control, and asking if hormonal birth control is a contributing factor to fertility issues later on in life, if prescribed as a young teenager, and if adolescents have used it for several years throughout.
An excellent, very relevant question. I think there is enough scientific evidence to come with a clear answer. Often reproductive dysfunction is hidden behind contraceptive use, because women with irregular menstrual periods, they often go to a general practitioner at an early age, late teenage years, and then they are prescribed oral contraceptives, so they have regular bleeding. And when they stop, 10 years later, usually their irregular pattern that they had before they started with resumes. So that is not caused by contraceptive pill use, but it's just hidden behind it.
Yes.
It is clear that even long-term contraceptive use, steroid contraceptive use, does not decrease chances. It may take a little longer, a couple of months longer, but it does not decrease chances.
And I think that's something that I still feel like we don't have significant data to make a statement about any one form of contraception. I think we have an over tendency to put hormonal birth control into one, or even contraception in general, into one bucket, rather than saying, well, there's combined oral, there's non-hormonal, and for actually many women, when you talk exactly about that, can we track women in a linear progression across their lives to truly determine what the changes and what are the things that have led to more significant or aggravating changes, we'll say. Mm-hmm. And when you ask any one woman, what form of contraception are you on? Well, they'll probably say that they were on this, then that, and then this for a while, and they'd had a terrible reaction to this one. And so actually being able to quantify the true effect of any one given form of hormonal contraception is actually quite difficult, especially when, if we were to put 1,000 women on the same form of contraception for the same amount of time and measure an effect, but we've never actually been able to do that. And what's worse is that when people come off their form of contraception, then we're met with this confounding factor of, well, it could be just age. And so it's actually quite difficult to get real truth data
Yeah, because indeed the different, but you see, of course, an increasing use of IUD, which hardly was used in younger women at all a while ago. And also you see, now in my country in particular, it was the country in the world with the highest proportion of young women using steroid contraception, but that has been decreasing that proportion every year. So steroid contraception, of course, is not without side effects, nothing serious long time, but certainly affecting quality of life during a pill intake for quite a few women. And also, of course, the idea of taking hormones, using hormones for a decade when you're young is scaring more and more people. So they say, well, why continue? Let's look for other possibilities. And of course, IUD is one of them.
Absolutely. We are nearly at the hour, and it's been so enjoyable just talking to you. It's very easy, and I could probably talk to you for a lot longer than just the hour. Thank you so much for your time and expertise and support. Generally, it actually means a huge amount to me.
I wish you best of luck with your efforts. I'm a supporter. Make it happen.
Thank you so much. And for anyone who is here, we'll be able to send out the recording of the webinar shortly. Once again, thank you so much, Professor Fauser.
Thank you for having me.
Take care.
Bye-bye.
Bye.